So, first of all, I would like to thank the organizing committee and especially my friend, Professor Vasilis Kostis, for this kind invitation. This is my disclosure. And here we see a projected increase of diabetes in the future. And we may see by 2045 an increase of up to 48%. That means more than 600 million people will have diabetes independently of gender. At the same time, we're seeing also an increase of obesity, according, as we can see here in the dark blue columns, according to the data of the enhanced study. Among the 650 million people with obesity, around 30% will have diabetes. And among the 425 million people with diabetes, around 90% have overweight or obesity. What does it mean? That diabetes and obesity occur together, and it seems to be a syndemic. And just to remind you that syndemic means two or more epidemics that interact synergistically and contribute to excess disease burden in a population. What happens in this obesity and diabetes endemic? Obesity promotes insulin resistance and beta cell decompensation, which are the main causes of diabetes. In addition, sleep disorders, the inability to be active, and the stigma in mental health worsen diabetes, which in turn increases obesity through medication or through neuropathy and decreased activity, through hypoglycemia and stimulation, of course, of food intake, and through the stigma in mental health. Physical environment and social environment act also synergistically. So that's why it's so important to treat diabetes, but not only diabetes, to treat obesity as well, and if it's possible, in a very simple way. Now the question is obesity a medical issue or a lifestyle problem? Many medical associations recognize obesity as a disease and as a progressive disease. And 90% of health practitioners recognize obesity as a disease, according to Action IO data, compared only to 70% of patients that believe that obesity is a chronic disease. In order to find people as obese, they should fulfill some criteria. For example, EMA defines obesity as an impairment of the normal functioning of some aspect of the body with characteristic signs or symptoms and cause harm or morbidity. Obesity is a complex and multifactorial disease. That means you have more energy intake compared to energy expenditure. A lot of factors go into this environment and hedonic input, and these factors seem to play also an important role. Keep in mind, dear colleagues, that metabolism is controlled centrally. We see here that these two hormones, insulin and leptin, inhibit ACT neurons and stimulate POMP neurons, so informing the hypothalamus about the energy status of the organism. Obesity is also associated with multiple comorbidities, such as metabolic comorbidities, including dyslipidemia, hypertension, type 2 diabetes, prediabetes, mechanical comorbidities, and mental comorbidities as well, including depression. Now the question is how much weight loss is needed to lose in order to improve these obesity-related complications. As you can see here, the more weight loss produces, of course, more health benefits. Weight loss has dose-dependent and tissue-dependent biological effects, and the benefits increase according to the percentage of weight loss. The greater the weight loss, as you can see here, the more the benefits, as you see here on this slide. There are different pharmaceutical options in order to manage obesity, and all of them are approved in the USA, but in Europe, only these three drug classes are for the time being approved. Which are the unmet needs in obesity management? We start treating diabetes and obesity as well with diet and exercise, which are the cornerstones. We continue with pharmacotherapy, although there is a treatment gap. between diet, exercise, and bariatric surgery in extreme cases. Until 2015, orlistat was the only anti-obesity medication approved in Europe for long-term management. And concerning bariatric surgery, in many countries, less than 1% of those who could benefit get bariatric surgery. This study refers to obesity and type 2 diabetes, called as diabetes, and they suggest that it should be treated with combined treatment strategies with anti-obesity and diabetic drugs as well at the same time. Let's have a look at the effects of the GLP-1 receptor agonist. According to the guidelines, after metformin, you can choose among other anti-hyperglycemic drugs, also new drug classes, the SGLT2 inhibitors, and GLP-1 receptor agonists. This drug class play an important role and is in the center of treating diabetes and obesity, as we will see. GLP-1 receptor bound to the receptors in the arcuate nucleus in the hypothalamus and stimulate POM neurons and inhibit ACT neurons. And so at the end, we have an increase in satiety and a decrease in hunger and energy intake. In this case, the study shows that liraglutide binds to its receptor on POM neurons to increase the expression of anorexigenic peptides, and conversely, it acts on ACT neurons to inhibit the expression of orexigenic peptides. And the net result is, of course, a reduction in appetite. This study shows that liraglutide reduces brain activity related to highly desirable food cues, which is very important for our patients. Aside from this, GLP-1 can also lead to augmented energy expenditure through favoring thermogenesis in brown adipose tissue. Glucagon seems to play also an important role because it can also directly stimulate brown adipose tissue or indirectly through favoring the FGF21 factor released in the liver, which acts activating thermogenic process in brown adipose tissue. All the studies show that all the GLP-1 receptor agonists more or less lead to a reduction of body weight. Let's have a look now on liraglutide and its role and effect in obesity. The SCALE study shows that liraglutide, as add-on to basal insulin and glucose-lowering agents, can lead to a reduction, to a great reduction of body weight. And aside from this, we can see also an improvement in glycemic control, as we can see here from the HbA1c reduction, and also we see that insulin dose is also reduced in these patients. The study published last year refers to healthy weight loss maintenance with exercise, liraglutide, or both combined. This study enrolled were enrolled adults with obesity but without diabetes, and all participants were randomly assigned for 1 year to one of these 4 groups. Exercise group, that means a moderate or vigorous intensity exercise program plus placebo. Liraglutide group, treatment with liraglutide, 3 milligrams per day plus usual activity. Combination group, that means exercise program plus liraglutide, and placebo group. The primary endpoint was the change in body weight, and secondary endpoint, the change in body fat percentage. And we see that this combination, exercise and liraglutide, can lead to a great reduction, to a marked reduction of body weight, and also to a marked reduction of body fat percentage. This is very important. When we lose weight, we wish to lose fat and not muscle. Let's have a look now at the role of semaglutide. Semaglutide is once weekly GLP-1 receptor agonist, and it seems to improve eating and to change the food preference and reduce appetite and reduce weight loss through different mechanisms, according to the mechanism of the mechanism of the GLP-1 receptor agonist. Semaglutide can access and activate neurons in the hypothalamus and brain stem. These are areas known to be involved in appetite regulation and reward. The SUSTAIN program has investigated semaglutide in nearly 14,000 subjects over an average of 1 to 2 years. And we see that the use of semaglutide can lead to a great reduction of body weight. And we see also a great proportion of patients, 50%, achieved a weight loss of 5%, and a smaller percentage weight loss of more than 10%. Semaglutide can change body weight and reduce body weight, not only as monotherapy, but also as add-on to other anti-hyperglycemic drugs, and also as add-on to basal insulin. It's very important. As everybody knows, insulin increases body weight, and this combination, probably remains weight stable and does not increase. The STEP program examined the role of semaglutide in different situations, between them in subjects with overweight or obesity, and in participants with overweight or obesity and type 2 diabetes. This study published, the STEP study published last year, included adults with obesity. And we see that the use of semaglutide in these subjects can lead to a marked reduction of weight. We see a mean weight loss of almost 15%. And we see also a great proportion of patients, 86%, achieved a weight loss of more than 5%. And 30% of these patients achieved a weight loss of more than 10%. 50% of the patients achieved a weight loss of more than 15%. It's very, very important. STEP 2 trial, published also last year, included adults with overweight or obesity and with diabetes. And in this case, we see that, again, semaglutide in a dose of 2.4 milligrams can lead to a reduction of body weight. We see a mean weight loss of almost 10%, and almost 70% of patients achieve a weight loss of more than 5%. Aside from this, weight loss was accompanied by an HbA1c reduction of 1.6%, a great percentage. And patients treated with semaglutide had greater improvements in cardiovascular risk factors and physical functioning compared with patients treated with placebo. Now, don't forget the oral semaglutide and its role in obesity. The PIONEER program enrolled 9,543 subjects, and it is shown that oral semaglutide can lead to a reduction of body weight, not only as monotherapy, but also as add-on to basal insulin, and also compared to other anti-hyperglycemic drugs. Oral semaglutide, as we can see here in the dark blue columns, can lead to a greater reduction of body weight compared to other anti-hyperglycemic drugs. For example, here, empagliflozin, sitagliptin, and liraglutide. Semaglutide, as we have seen, offers the benefits in both injectable and oral formulation. However, selection of the most appropriate formulation can be made on an individual basis to best suit the patient's preferences and needs. This is the magic word, individualized. And this slide shows the advantages and disadvantages of injectable semaglutide and oral semaglutide. Okay, oral is oral. and the patient needs to follow specific instructions daily. And sometimes these patients receive so many drugs, and one more is not so convenient. On the other side, it's injectable, but once a week, and they don't need to follow any dosing instruction. In any case, we have to individualize according to the patient we have. Don't forget the other one, once weekly GLP-1 receptor agonist, dulaglutide, and we see that dulaglutide can also lead to a reduction of body weight in a dose of 4.5 milligram. We see with this dose a greater reduction, and also a 50% of these patients achieved a weight loss of more than 5%. This review refers to diets and drugs for weight loss and health in obesity, and this table shows that among all anti-obesity drugs, liraglutide and semaglutide have an advantage because in addition to body weight reduction, can also improve glycemic control much better than the other anti-obesity drugs. Now, the introduction of these drugs increased, of course, the scientific and clinical interest in incretins. Now, combining the body weight lowering and glucose lowering effects of GLP-1 with a more potent improvement of beta cell function through additional GIP action could potentially offer a more effective treatment of diabetes and obesity with fewer adverse effects than the selective GLP-1 receptor agonists. Some studies suggest additive or even synergistic effects when combining GIP and GLP-1 for the treatment of this called diabetes. This slide shows the biological effects of GLP-1 on the left and GIP on the right. And you see here the direct and indirect effects of these incretins. Aside from the GLP-1 receptor agonist, GIP receptors also play a role in the hypothalamus. It's involved in the regulation of energy intake and food. It's very important to keep in mind that both of them are involved in the regulation centrally of energy intake. This combination, the GIP and the GLP-1, can lead to a reduction of HbA1c level. That means we have a better glycemic control, and additionally, we see also a marked reduction of body weight. So these both incretins act synergistically. But aside from this dual agonist, we have also, and we see in the future, a three agonist. This three agonist can, through this study published last, I think, 2 or 3 months ago, shows that integrating GIP activity into dual GLP-1 and glucagon receptor agonist provides improved effects not only on weight loss and glycemic control, but also on dyslipidemia and hepatosteatosis as well. This triple agonist, as you can see here, can lead through different pathways to weight loss. There are several pathways leading more or less to weight loss, this triple combination, GLP-1, glucagon, and GIP. However, it is of paramount importance that use of the currently available medications is optimized. What does it mean? To provide the right treatment to the right patient at the right time. As with any medical therapy, there are also inter-individual differences in response among participants, including the possibility of less than 50% weight loss to 20% or greater weight loss, suggesting that individualization and precision treatment might be necessary to achieve greater disease modification. The challenge is to identify and validate biomarkers for drug selection, for this drug selection. For the time being, we don't have such biomarkers in order to select the right drug for the right patient. This review published also last year aimed to analyze the weight loss effect of non-insulin glucose-lowering drugs in patients with type 2 diabetes. And the authors conclude that among antidiabetics, the new drugs, in particular, the new molecules of the GLP1 receptor class, are the most effective in inducing weight reduction in patients with type 2 diabetes. In these patients, weight loss combined with other extraglycemic and extrapancreatic effects has a positive impact on cardiovascular risk with a consequent reduction in mortality and morbidity of the disease. This review also published last year aims to remind us that obesity management should be the primary treatment goal for type 2 diabetic patients, and that it is actually time to reframe the conversation. The time is right to consider the addition of substantial weight loss as a principal target for the treatment of many patients with type 2 diabetes. Such a change in treatment goals would recognize obesity as a disease with reversible complications and require a shift in clinical care. This approach would address the pathophysiology of the disease process for type 2 diabetes and reap metabolic benefits far beyond glycemia. So, concluding my talk, let's have a look at the key points. Management of obesity in individuals with type 2 diabetes leads to significant cardiometabolic benefits. Type 2 diabetes and obesity treatments may be best suited for precision medicine approaches rather than a one-size-fits-all paradigm. Treatment of both obesity and type 2 diabetes can be addressed simultaneously with the use of weight-reducing antidiabetic agents and current FDA-approved anti-obesity medications. Weight-reducing antidiabetic agents should be prioritized in these patients. Emerging antidiabetic and anti-obesity medications have a greater weight loss potential, which will help close the efficacy gap, as we have seen previously, between medical and surgical management of type 2 diabetes with obesity. We have to look not only we have to have not only a glucocentric approach, but also a weight-centric approach. Both of them play an important role for treating diabetic patients. For the time being, we use GLP-1 for type 2 diabetes and obesity. We are looking for using them for type 1 diabetes, pre-diabetes, NAFLD, and PCOS, and who knows in the future, probably we can use them for other diseases such as neurodegeneration, psoriasis, and coronary heart disease. Now the question is, despite all the benefits of the GLP-1 receptor agonist, less than 10% of the population were receiving GLP-1 receptor agonist, a very low percentage. Probably there are some barriers. The knowledge about the novelty of these drugs, the knowledge of the lack of knowledge of the trial results, the practicalities of initiating these drugs, the side effects, other barriers, who knows. In any case, we have to overcome all these barriers in order to help patients with type 2 diabetes and obesity. So, dear colleagues, setting the benefits of GLP-1 receptor in the center of discussion, it seems that the new and charming era has begun for diabetes and obesity. And with this, I would like to thank all of you for your attention. Thank you very much.